So today we'll be discussing a very interesting topic, and that is ABG. Now, I always think that ABG is one of the best and one of the best investigation to do, because that is the one blood test that tells you about so many things. So one of the any patient, if any patient is unstable, or if any patient has undergone any surgery, then it is very, very essential to do the patient's ABG to come to know whether he is stable or not. If ABG is bad, then the chances of patient worsening is very, very high. That patient need utmost care. So one of the most important thing is pH. So the patient pH, the normal pH has to be in between 7.35 to 7.45. If the pH is less than 7.35, it means the patient has acidemia. And if the patient's pH is more than 7.45, we say that the patient has alkalemia. And both are bad. And acidemia is significantly bad. If pH is less than 7, the patient may be in a really, really bad trouble, and the chances of survival of the patient may significantly reduce if the pH is less than 7. Because if the pH is less than 7, means the patient has significant acid in the blood, and at this much of acidic environment, heart cannot pump at all. The contractility of the heart significantly reduces, and the vasopressors, dopamine, adrenaline, all these medicines, they don't act very, very well at this much of pH. So acidemia must not be there, and if it is there, it has to be treated. So one of the most important thing we have to see is acidemia. Here the pH is 7.37, so there is no acidemia. The second thing is this PCO2. The PCO2 must be between 35 to 45. If it is more than that, it means that there is increased CO2 retention by the body, and this is basically a type 2 type of respiratory failure, where there is failure of the lungs to excrete this CO2. So this can be because of multiple reasons. This can be because of the reduced respiratory drive, or this can be because of the significant bronchospasm. This CO2 retention is extensively common in patients with COPD, emphysema, because the lungs are so much damaged that this airway, these are so much damaged that the CO2 cannot pass outside the mouth. Before passing through the mouth, in the respiratory tract only, the CO2 gets trapped. So CO2 retention is extremely common in OSA patient, in obese patient, in COPD patient, in emphysema patients, and as this patient has PCO2 of 86, as soon as the CO2 starts rising more than around 70, the patients start becoming drowsy. Patients prefer to sleep, and if this CO2 retention is not recognized more than 100 of PCO2, the patient can have severe respiratory acidemia, and patient may die also. So the CO2 retention has to be very, very seen carefully and closely. So if the PCO2 is less than 35, means patient's respiratory drive is much more, means the patient RR is more than what we expect, which means the patient has tachypnea. And this tachypnea can be because of anything. It can be because of pulmonary edema, it can be because of the fluid overload, it can be because of CKD, it can be because of heart failure, it can be because of MI, it can be because of anxiety also. So we need to find out that what is the reason for the CO2 wash out. So if the PCO2 is less than 35, lesser and lesser PCO2 will tell us that patient is more and more and more tachypneic. So PCO2 gives us a wonderful finding of the respiratory drive or the possibility of COPD. In this particular ABG, we can see that CO2 is so much high and bicarbs are so much high. It means that this is a very, very typical case of COPD, and they tend to have higher and higher PCO2 levels, and they don't get settled very easily. It may take few more days, like it may take around 4 or 5 days for this PCO2, or maybe more than that, to get settled. This PO2 is one of the most important thing. This PCO2 is a pressure of oxygenation in the blood, and there is a linear relation of this PO2 with saturation of oxygen when seen by pulse oximeter. So when we say that the PO2 is 60%, it means the patient must have saturation of at least 90%. So as soon as it touches around 70% of PO2, the saturation that is shown by pulse oximeter must be around 100%. So if PO2 is more than 100%, it means that the patient saturation has to be more than 100%. Lesser and lesser is the PO2 means the patient has hypoxemia, and that is a very, very bad sign. So if you want to see whether the patient is intubated well or breathing well, or if the patient has proper saturation or oxygenation, ABG helps a lot. If ABG shows that the PO2 is 70 or more than 70, it means the saturation is 100%. 100%. And if PO2 is less than 60%, it means that patient saturation is definitely less than 90% if it is ABG for sure. Because in VBG, very commonly, the PO2 will be always less than 40 to 50% only. Because it is a venous blood sample, there will be definitely lesser oxygenation. So other things which are very important are, which are told by the ABG, is the sodium. If any patient is presenting with altered mental status, we may very commonly suspect hyponatremia or hypernatremia. So before all the other blood reports come, we can simply see the ABG and we can find out the sodium, which is right here. So if sodium is normal, it means the chances are very good that the patient does not have hyponatremia or hypernatremia. But if this sodium shows a sodium value of 153 or 160 or 120, 112 or 108, then we definitely have to trace the kidney function test and the blood that we have sent for serum sodium levels. So if the sodium reflected in the ABG is normal, it is almost 90% sure that the patient's sodium is normal. And if this sodium value is abnormal, we definitely have to trace the serum electrolytes for actual sodium value, and we have to correct it as per the sodium value which is there. Very commonly, in post-operative patients, in bypass patients, in exploratory laparotomy patients, or in tachypneic patients, or in elderly patients, this potassium plays a vital role, because this potassium is very, very important for all the gut muscles, all the diaphragm muscles, and all the muscles of the body. So if the patient is in the hospital, in the ward, in the ICU, if the patient is tachypneic, more and more diaphragm muscles are used. If the patient has undergone surgery, the constipation is very common, chances of intestinal obstruction is very common. So gut muscles, or all the muscles, mainly the gut muscles, diaphragm, they need the potassium very, very importantly. So the potassium has to be in between 3.5 to 5.5. So if it is less than 3.5, definitely the patient may need the potassium correction that we give around 2 to 8 apples per day. We can very easily give depending on the potassium value. So potassium has to be seen, and this ABG can directly tell us about this potassium value. Glucose is extremely important. As we can see, ABG can immediately pick if the BSL is suppose more than 200, or if it is less than 100. We should be really cautious. If it is more than 200, means the patient may have hyperglycemia. The patient may need insulin infusion, or we may need to omit DEXA or Hydrocort or any other medicine which may increase the sugar, because in post-op patient, post-bypass patient, post-wall replacement patients, in surgical patients, sugar control is very, very necessary. So the ideal sugar level target, ideal glucose level target should be in between like 100 to 180. If it is more than 200, definitely we need to control that sugar aggressively. If it is less than 100, we need to take care to prevent the hypoglycemia. Otherwise, the patient may have profuse sweating, may throw convulsions. So hypoglycemia or hyperglycemia, both are bad. Now, the next is lactate. Lactate is one of the most important thing. Lactate has to be less than 2. If it is more than 2, it tells few things. One is dehydration. So patient may not be adequately hydrated. Patient may need more fluids, or the patient may be, if it is more than 2, it may indicate that the patient has significant fluid loss. That can be third the space fluid loss. Patient may have capillary leak, or patient may be on NORAD, adrenaline, dobutamine, or other vasopressor support. Very commonly, if the patient is on this vasopressor support, or the patient is significantly dehydrated, the lactate will be more than 2. If it is less than 2, it means the patient hydration status is optimal and patient does not need an extra hydration. And this hematocrit can be definitely helpful. Hematocrit like up to 35 to 45 also is pretty accepted. If it is more than 45 or if it is more than 50, it may indicate hemo concentration, because this hematocrit gives us directly a window for his hemoglobin. Hematocrit means it is actually the percentage of the hemoglobin that is present in that particular blood sample. So if any patient who has shock, or if the patient has GI bleed, or if the patient has undergone any surgery, then whether to give the blood or not, whether to expect hemoglobin drop because of the bleeding or not, this hematocrit can give us an idea. Because if hematocrit is between 35 to 45, it means there is adequate hemoglobin in the blood. Patient does not need any blood transfusion, or the we need to simply monitor these hematocrit levels in successive ABGs. So if 36 is the hematocrit, in the next ABG, if it falls to 23, it means the patient may have blood loss and we may need a look for it, because this patient, if hematocrit falls, then the lactate may again rise, because the oxygen carrying capacity of the blood will definitely reduce, and acidemia will rise and shock may rise. So hematocrit can directly give us a window to the direct HB or hemoglobin of the patient. Now this bicarb is very, very essential. Normal bicarb level should be less than 24. It should be around 16 to 20 to 24. If it is more than 24, it means the patient has alkalemia. If it is less than 16, then we think of the patient may have significant acidemia. 20 to 24, we say that the patient does not have any acidemia or alkalemia. Less than 20, we may say that the patient has mild acidemia. Less than 60, we can say that the patient has moderate acidemia. So in this case, as the patient has significant CO2 retention, the ABG range should be in between 7.35 to 7.45, as this is around 7.37. So it is towards the acidemia side. So this patient actually has respiratory acidemia, and which is being compensated by the metabolic acidemia by the body. So if bicarb is less than 20, we call it as towards the acidemia side. And if it is more than 24, we call it as alkalemia side. So lungs, which are told by CO2, and bicarb, which are told by kidney. So these are the two compensatory mechanism for each and other. So lungs compensate for kidney and kidney compensate for lungs. And among this, lung is very fast. Lung can retain the CO2 fast, and lung can do washout of the CO2 fast. So lungs can act very, very fast, but kidney takes time. kidney takes time. So if the patient has metabolic acidemia, means bicarb will be less than 20, then body causes tachypnea and lungs cause tachypnea. This is how CO2 is excreted more and more to create respiratory alkalemia. So in this case, what we are saying is lungs or the respiratory system is not throwing out CO2. That is the reason why CO2 is being retained. So CO2 has increased, causing a respiratory acidemia, which is being compensated by kidney as a metabolic alkalemia. So these are the two compensatory mechanisms of lungs and kidney towards each other. So the this is pretty compensated because the pH is in the normal level. If it is not compensated, we would have said it is not compensated. But as the value is in the normal range, it is called compensated. If this value would have been less than 7.35, we would have said that it is not compensated. But here, as it is normal, we will say it as compensated. This saturation is definitely told us about by the PO2. As I told, 60% PO2 means saturation must be 90% on the monitor or by the pulse oximeter. 70% PO2 means most of the time the saturation will be around 90%, and 80% to 100% it will tell us that the patient saturation is around 100%. And if the PO2 is 100% means the saturation is 100% or more than that also. And lesser the PO2 than 60, definitely the saturation will be low. So if the patient saturation here it is showing 88% means this is 100% ABG, because in VBG we always get PO2 of mostly less than 40% only. So if it is 40%, VBG or venous blood gases will always show saturation of around 60-65% only. It will never rise to more than 80%. So as this ABG sample is showing saturation of 88% means this is for sure 100% ABG only. And the last thing is hemoglobin. So this ABG is one such test which is actually a combination of so many tests. So this tells us about lungs by this PO2 levels and PO2 levels, PCO2 levels. This tells us about the patient's respiratory rate directly or indirectly, because if PCO2 is low means patient is tachypnic, and PCO2 is high, it means the patient either has COPD, bronchospasm, or maybe patient has apnea or reduced respiratory rate. So this ABG is telling us about lungs by these all method. Now this ABG is also telling us about kidney or the electrolyte status by sodium potassium, because this potassium can be low because of the dehydration, because of the loose motions or vomiting or third fluid space loss. So if the patient has loose motions, that can tell us hypokalemia. So this ABG can tell us about that diseases also. It tells us about glucose so that we can treat the hypoglycemia or hypoglycemia at optimal level. It is telling us about lactate. So indirectly it is telling about whether the patient has shock or whether the patient is needing any inotropic support or the patient is well hydrated or not. Next thing it is telling about is hematocrit, means in short about HB, means whether the patient has capillary leak or whether the patient will end up in shock. These things are told us about by the ABG. Next thing it is telling us about bicarb. So from the bicarb point of view, we can tell us whether the patient has chronic alkalemia, chronic acidemia or not, and in general regarding the kidney status of the patient. It is telling us about the saturation, means the patient is optimally uh, ventilated or not. So this is one of the very beautiful tests. It is a single test which tells about so many organs at a time. A single test telling us about lungs, kidneys, hemoglobin, oxygenation, respiratory drive, blood loss, dehydration, glucose status. That is the reason why any patient, if any patient we think that he is unstable or is not getting treated, monitored optimally, we must do ABG to find out any problem if the patient has underlying. So this was all about ABG, and I'll come again with some other ABG's topic. Thank you.